So welcome, I'm Rachel Stack. I'm the Quality Improvement Lead for the Southwest LHIN, and I'm going to be going through the third session of the HealthLinks Learning Collaborative pre-work session. So for today's webcast, we're going to be giving a more in-depth view of the quality improvement approach that we've taken with HealthLinks. And so for this presentation, we're going to be introducing the quality improvement approach, talking about quality improvement in HealthLinks and how we've integrated that, talk about some of the tools that we've used to infuse quality improvement within HealthLinks, such as the Quality Improvement Enabling Framework and the driver diagram. And then we have Nicole is going to be talking about the Huron-Perth measurement plan as an example of a measurement plan for HealthLinks. And then more information about how we can get some more information about quality improvement through the Institute for Healthcare Improvement, IHI Open School. So in terms of the quality improvement approach, quality improvement is the systematic approach to making changes that lead to better patient outcomes, health, stronger system performance and care, and enhanced professional development. And so we're using this method because we want to make sure that we do take a very systematic approach to implementing HealthLinks and using quality improvement. And it draws on a combined and continuous effort of all stakeholders, healthcare professionals, patients and their families, researchers, planners, and educators to make better and sustained improvements. So how are we linking quality improvement in HealthLinks? HealthLink contributes to the Ministry of Health and Long-Term Care's vision for system-wide quality improvement by promoting collaboration and coordination of quality improvement objectives across partner organizations. It's intended to improve the level of communication and collaboration among providers who share in the care of patients identified as having high care needs and who would benefit from the most coordinated care planning. A quality improvement approach will help us to improve the quality of care for these individuals. And it also provides us an opportunity for health sector partners to learn from peers on the types of actions that can be taken to achieve quality objectives. So we have been using a number of different mechanisms and a number of different ways and methods to introduce quality improvement within HealthLinks. We have frontline interdisciplinary teams learning to apply QI tools and methodology to implement and spread change ideas. And some of the things that we've been able to access are the Health Quality Ontario's Ideas program, collaborative learning, which we are talking about today, the IHI Open School, and different workshops that are happening within your area. The goal of HealthLinks is to empower teams to set goals for improvement, conduct tests of change, and collect and analyze data to determine change success. So one of the tools that we have been using with the HealthLinks Leadership Collaborative is the Quality Improvement Enabling Framework. And we've used this to ensure that we have all of the factors and enablers present to be successful in implementing HealthLinks. And the Quality Improvement Enabling Framework represents the foundation for improvement and includes the key enablers or pillars for boards and senior leaders within organizations to consider when creating an optimal environment for improvement, internal and external. So thinking about all of the things that we need to do to be successful in implementing HealthLinks. Integral to the success of the QI programs are enablers, strong leadership, a supportive culture, and staff who are versed in quality improvement methodology. This slide shows the Quality Improvement Enabling Framework, and the HealthLinks Leadership Collaborative have reviewed all of the different pillars within the Quality Improvement Enabling Framework to ensure that we have enablers and activities in place to build on each of these pillars. So in terms of leading, we have steering committees and oversight structures in place. In terms of building capacity, the Learning Collaborative is one of the ways in which we are trying to build system capacity for frontline staff and leaders to implement HealthLinks. We're looking at different ways of applying evidence, such as using patient experience or measurement as well to inform our decisions as we move through HealthLinks and implement. We're enhancing health system information systems. We're looking at engaging. We're making sure that we are talking with patients and families around the coordinated care planning process and involving them in the planning of health links and implementation. And then we're looking at motivating, showing that to other healthcare professionals a strong case for change and the potential improvements for patients and family, and making sure that we're communicating that to everyone. So this is a tool that we've used to ensure that we have all the factors in place to ensure that that Health Links is embedded as a quality improvement approach. Then the other quality improvement tool that we have used to look at the quality, to embed the quality improvement process within Health Links is the driver diagram. For those that may not be familiar with a driver diagram, it describes the system that you're working in. It's used to test theories about cause and effect, and test your theory about how the system you are working in and wanting to improve actually works. It's meant to be updated throughout the project, and it shows the change program in a single diagram and also provides a measurement framework for monitoring progress. So we really wanted to understand, as a Health Link leadership collaborative, we wanted to understand how the system in which we were trying to make improvements was working, and thinking about what we thought we would need to do in terms of making improvements within Health Links. And so the Health Links Leadership Collaborative was instrumental in the development of the driver diagram for Health Links. So on the left of the driver diagram is an aim statement. And the aim statement for Health Links is to reduce avoidable healthcare utilization in order to better meet the needs and support patients and families with the greatest healthcare needs in the Southwest LHIN. You can see that this is a very broad statement for Health Links and really encompasses all of the Health Link populations. Typically within a name statement it would be a bit more specific and include a target, and we will be revisiting this in the future to look at being more specific around the aims, and even doing a deeper dive in terms of the populations that we're serving, and trying to make this a bit more specific. Okay, so what you see on this slide is a draft driver diagram. And we're also going to include this as an attachment within the website so that you can download this and see this in the copy of the draft driver diagram in more details. On the left of the draft driver diagram is our aim statement. And I just reviewed the aim statement, but it's very broad and encompassing for all of Health Links and all of the populations. To the right, as you move to the right, are the primary and secondary drivers. And then to the far right is the change ideas. The change ideas are what we feel that we have, or the different types of ideas that we have, or concepts that we have, that we feel will drive the change, will impact the secondary and primary drivers and impact the change in the aim. So if you're reading the driver diagram right to left, it will answer the question, why? Why are we working on this project? If you're reading the driver diagram left to right, it will answer the question, how? How is the aim, or big dot, going to be achieved? So when we're looking at the aim to try to reduce avoidable healthcare utilization in order to better meet the needs and support patients and their families with the greatest healthcare needs in the Southwest LHIN, we do feel that there are a number of drivers that will help us to achieve that. And just looking at the primary drivers, we feel that we need to have shared leadership and accountability, effective team functioning and maximized health and human resources, timely access to appropriate care and services, identification of patients with high health care needs, and person and family-centered care. I'm not going to go into all of the details regarding the secondary drivers and the change ideas, but this is something that we will be looking at as we go through the Learning Collaborative and thinking about all of the different areas and different change ideas that we can implement that will impact that aim and big dot. As well, I should mention is that with each of the primary drivers, we have corresponding indicators that will help us to ensure that we understand whether we're making a change in these areas. And so we will be talking a little bit more about the measurement plan, but how these indicators will inform us of whether we're reaching that big dot aim.
My name's Nicole Robinson, and I'm going to talk a little bit about some of the provincial, LHIN, and HealthLink specific key indicators, measurement, and reporting that aligns to supporting improvement for HealthLinks. So in the slide, what you'll note is that there are HealthLink indicators of success that have been identified by the province. And at the outset of the HealthLinks intervention, they sort of identified some of the near-term, longer-term, and I would say more future-focused indicators. So you'll note in the red as on this slide, you'll see the setting the stage for coordinated care. It's kind of the first area that we'll get into. And really that aligns with all complex patients having a coordinated care plan, and complex patients and seniors will have regular and timely access to a primary care provider. And through a lot of the HealthLinks work that's happened in the Southwest and across the province to date, those are key areas of focus at the actual HealthLink level that I think you'll find are particularly relevant. And then moving the needle. So this is a little bit of a more longer term strategy, and these are some of the indicators that were identified by the province as having some level of importance. So that's reducing the time from primary care referral to specialist, reducing the number of 30-day readmissions to hospital, reducing the number of avoidable ED visits for patients whose conditions are best managed elsewhere. And then we will note that with that particular indicator, patients with conditions that are best managed elsewhere, this indicator really does focus on less complex patients with very specific conditions, things like urinary tract infections, colds, ear infections. Those are the types of conditions that really indicator number 3 is speaking to. So maybe not a key indicator for us yet at this point. Reducing time from referral to home care visit, reducing unnecessary admissions to hospitals, and faster primary care follow-up following a discharge from hospital in an acute care setting. And I will say that sometimes you'll see this indicator and you'll also see it included and profiled on the HealthLink driver diagram, noted as % of clients seeing their primary healthcare provider following discharge within 7 days. So now we're moving into the area of green. And again, these are a little bit longer, beyond 2 years. These will be a focus for our HealthLinks. So that's really around some longer term changes, enhancing the health system experience for patients with the greatest healthcare needs. We are doing some work at this time already to try and capture some patient experience indicators here in the Southwest. Also reducing ALC rate, again, a longer term strategy. And reducing the average cost of delivering health services to patients without compromising the quality of care. And you'll see this reflected in our driver diagram as reduced utilization, and how we're really looking to monitor that for HealthLink patients is looking at things like revisits to the emergency department within 7 days, and also readmissions to hospital for various reasons and for specific chronic conditions. So through utilization of hospital services, that's really how that frames the definition for how we're looking at this and really trying to monitor outcome progress here in the Southwest. So on the next slide, you'll see the measurement plan, and this is just at a very, very high level, taking some of what's reflected in our driver diagram, linking it to the provincial indicators, and also really how does this align with the Southwest LHIN IHSP, which is our Integrated Health Service Plan. So you'll see under the provincial HealthLink indicators, at the end of the day, we're really looking to hopefully have an impact on reducing avoidable healthcare utilization. So again, that's currently being measured and monitored through reduced ED visits and acute inpatient discharges. We could also experience reduced utilization through things like CCAC and or primary care. Also reducing readmission rates, and then again that really speaks to the avoidable readmission rates for patients with identified chronic conditions. So strategic alignment with the LHIN IHSP, we have a big dot as part of our IHSP, which is sort of a 3-year high-level goal, where we're really trying to reduce revisits to emergency department and also to reduce readmissions or avoidable days. So you can see that this aligns with both the provincial and Lean approaches, and I'm sure that this aligns with many of the strategic plans for your various organizations that you're coming from. So long-term outcomes to reduce, again, healthcare utilization in order to better meet the needs and support patients and families with the greatest healthcare needs in the Southwest LHIN. The current status of the HealthLink project, we're really looking to develop process indicators to accurately measure and monitor changes that are currently happening and are relevant to HealthLink implementation in the Southwest. So we'll be going through some of those examples. On the next slide, what you'll see is in the Southwest, we've actually come up with a common definition or a way of defining our HealthLink population. And that really speaks to the top 5% of users with high care needs. You'll also hear this referred to as maybe people that are frequently utilizing health services. And the actual definition is based on, again, who are the top 5% of people who are utilizing the emergency department and are also being discharged from hospitals, so are having the greatest healthcare utilization for acute inpatient services. In the Southwest LHIN, that definition, based on when we ran this data for 13-14, it identified 2,253 people in the Southwest LHIN that meet that criteria. You can see in the slide, we actually have identified the number of people and how that breaks out to the health links across the Southwest LHIN. In the red box, you'll see Huron-Perth contributes 354 of the people that are identified at the LHIN level. So those are the users with high care needs in the Southwest LHIN, and we've provided this information and unique patient identifiers to each of the health links across the Southwest. So to give you an example, we're taking a patient from the Huron-Perth Health Link that has identified high care needs. So this is one of the 354 people that we have identified from Huron-Perth. This person happens to be a male in his 70s, lives in Huron County, has visited 3 different HSPs in 2013-14, contributing a total of 5 emergency department visits and 5 hospital admissions. He's currently on CCAC service and has COPD and CHF and has been admitted to hospital for treatment of both conditions. The next slide shows you an example of similar patients across the Southwest LHIN and the impact of their contributions. So you can see, based on utilization in 2013-14, that there have been over 4,000 hospitalizations for patients with similar conditions and over 3,200 patients with COPD and CHF in the Southwest LHIN. This has contributed to over 31,000 hospital days, comprised of both acute care days and also ALC days in the Southwest LHIN. So in alignment with the patient that we're profiling, who was Will, you can see the impact of the various wills across the Southwest LHIN and really how the HealthLink strategy is targeting improvement to overall utilization in these areas. The next slide shows you how in the Southwest, some of the tools that we have that enable us to monitor progress for users with high care needs in the Southwest LHIN. So one of the key tools that you'll see actually screenshots profiling here is the Regional Integrated Decision Support System in the Southwest LHIN, or otherwise known as RIDS or IDS. This business intelligence tool really allows us to link hospital systems from across the Southwest LHIN as well as CCAC information, so that it allows you to go down into a patient level, which is what you see in the slide, showing encounters from October 2013 to October 2014. In this view, you can actually see that for the male, age 78, coming from Huron County, you can see the services that this person has encountered over time. So for example, you can see the number of ED visits, which shows 3 ED visits. You can see same-day surgeries by the different unique encounters. And then looking at acute inpatient admissions, you can see that this person has had 5 different acute inpatient admissions, over a period of time, resulting in a length of stay that's really shown by the length of the blue bars in the visual that you're looking at. As well, you can see when this person, we don't know again who it is, but for example, we're calling this person Will. You can see when the person started and stopped CCAC service and the fact that they're currently on CCAC service. And we've also noted when the person has actually began participating in an active coordinated care plan through the Huron-Perth HealthLink. On from identification to active care plan. So really what we want to highlight from this slide is that we've done some work with our initial pilot with Huron-Perth, figuring out ways to identify and help support the actual health links in identifying who their population of patients with high care needs are for each of the individual health links, and really how that information will be shared from hospital information data systems, from the regional integrated decision support system, to the actual health links, to the point of identifying and contacting patients or clients, potentially as coordinated care candidates. So we really just wanted to provide an update and to let you know that this information will be further reviewed on day one in an example that will be provided by people who are actually using the information to coordinate care planning for some of these people. So if you're not familiar with this work, you'll be socialized to this in the future, and this will be a resource available to you and all HealthLink teams across the Southwest LHIN as we continue to progress this work. So lastly, we wanted to provide a bit of an update on some available resources that are available to you prior to starting into the Learning Collaborative. So you can see in this slide we've included some information about the Institute for Healthcare Improvement, or IHI Open School. This resource is available to all participants of the Learning Collaborative, and you can see information is included here. So if you need a refresher on some basic QI or improvement methodology, it would be important for you to access these resources prior to beginning the Learning Collaborative. So you've now completed the pre-work session, and the next step will be to participate in the modules.